Thanks so much for joining us. Welcome. You have joined What's New in Pneumococcal Disease Control, the launch of a new report for World Immunisation Week and Africa Vaccination Week. Did you also know that today is International Day of Immunology? I did not know that. I was told that, but it is. My name's Leith Greenslade from Every Breath Counts, and the report is the work of a new group called Secure PCV, which includes some of the world's leading scientists on pneumococcal disease and vaccines. And they're joining forces now because new evidence has created opportunities for governments to strengthen their pneumonia vaccination programs. So on the first part of the call, I'm going to take you through the report, and then we're going to hear from three members of the Secure PCV group, Dr. Anik Sidibe, Dr. Faiza Jahan, and Dr. Ruth Lucinda. And we have a very special guest known to many of you. It's Veronica Denti, who for many years was Gabby's expert on PCV and who now runs her own organisation called Veda Global Health. Please put comments in the chat throughout, and we're recording this, and we will share this recording widely. So let me share my screen, and if everybody could put their videos off so we can all focus on the slides. Thank you. Okay, so what's new in pneumococcal disease control? Let's take a look. So this report was produced by the Secure PCV group. I've already explained to you. This is a new group. I will share in a minute a link where you can see exactly who they are. We have three of them with us today. And why are they doing this now? So let me take you through some of the data. Pneumonia is the leading infectious cause of death among children and adults. We know that. The latest global burden of disease, which is 2023 data, has 2.5 million deaths, and that includes 610,000 among children under 5. Now, 1/4 of all pneumonia deaths are caused by one bacterium, which is vaccine preventable, Streptococcus pneumoniae. And you can see in the pie chart there, the orange piece is Streptococcus pneumoniae deaths of all global pneumonia deaths. So it's still a huge problem. Now, there are many advances in vaccines that have been happening in recent years. There's a new simplified dosing schedule for PCV, and more data is coming through on the secondary benefits of PCV that make high coverage pneumococcal vaccination programs even more cost effective now as vaccine budgets are squeezed. So let's take a look at deaths. So in 2023, pneumococcal disease itself, we're zeroing in now on pneumococcal disease, caused 674,000 deaths across all ages. It mainly causes pneumonia deaths, but also we can't forget meningitis. A lot of meningitis, 16% of meningitis deaths are caused by Streptococcus pneumoniae. Children are really severely targeted. So you have, of all deaths from pneumonia in children under 5, 32% are caused by Streptococcus pneumoniae. So it's, even despite the PCV vaccine, it's still a massive killer. But it's also a huge problem in adults, particularly adults over 70, where you have a lot of Streptococcus pneumoniae deaths. So it's the very young and the very old. It's a particularly vicious bacterium. 1/3 of all Streptococcus pneumoniae deaths are in Africa, which is significant. So also Asia, you can also, and we've broken it down there by age. Look at the children dying in Africa from Streptococcus pneumoniae, and then look at the older adults in Asia. So it's very important to look at this regionally, but it's Africa and Asia that's sort of screaming out in terms of the burden. So this is global burden of disease deaths. We can also look at other data sources. So the CHAMP source of data, which you probably all know. If you don't, CHAMP stands for the Child Health and Mortality Prevention Surveillance Network. And CHAMP's data, which they do autopsies on children who have died to determine what caused their death. And they're finding in community outside of hospital settings, 35% of pneumonia deaths in children in the CHAMPS database are caused by Streptococcus pneumoniae. There's also quite a lot of hospital deaths, but not as many. So it's the CHAMPS data really confirms a lot of what the GBD data is telling us. What's happening over time? You can see between 2000 and 2023, pneumococcal disease deaths fell by a large amount, particularly among children. That's the orange section of the chart. they fell by 70%. So that's definitely PCVs making a big contribution there. But you can also see they're rising among the elderly. That's a function of age, but aging of populations, but not only. I think we need better strategies to control Streptococcus pneumoniae in older adults. So just a few interesting facts. Pneumococcal serotype distribution is shifting rapidly. So the vaccine targets, PCV13 targets 13 of them. You would expect in high vaccine coverage areas, those serotypes decline, and that's happening. But non-PCV serotypes, I've listed some of them there, are increasingly observed in high PCV settings. So the vaccine is definitely changing serotype distribution. And in many countries with low PCV coverage, you're seeing both still in relatively high distribution. So we have a vaccine, the PCV. We've been talking about it. It's a very good vaccine. It's been around for a long time. But look at the coverage. Global coverage is 67% across all countries. That's the average. That's not very high. It's nowhere near the 90% that's required to achieve the global goals. And then you look regionally. Some regions are doing much better than others, but they're all below the target. We have had, as I said, a strong PCV vaccine. So you have to ask the question, why is coverage so low despite more than 2 decades of a PCV? We've also had a very affordable PCV vaccine, the $2 per dose vaccine from the Serum Institute of India called Pneumococcal. That's been around since 2020, so coming up over 5 years. But only 9 low and middle income countries are using that lower cost PCV. Once again, why? And then there's a whole raft of higher valent PCVs coming online, 15, 20, 21. Now, so far, they're mainly being used amongst adults in high income countries. So they haven't yet reached low and middle income countries. But in terms of pneumonia vaccines more broadly, and this is going to become important later in the presentation, we have an RSV maternal vaccine. Only 2 low and middle income countries are currently using it, Argentina and Brazil. And we also have monoclonal antibodies, only high-income countries are using. So these new RSV tools are definitely a complement to the pneumococcal vaccine, but currently in very low use. There's also Group B streptococcus vaccine coming, a maternal vaccine, and a Klebsiella pneumoniae vaccine in the pipeline. All to say, the existing and pipeline vaccines for pneumonia, it's a rich, rich pipeline of tools now to prevent pneumonia. This is one of my favorite pictures. You can see pictures like this in most countries where PCV is introduced. Look at what happens to cases. This is children, cases of pneumococcal disease after PCVs are introduced. And we see this all over the world. Sharp, sharp reductions in cases and, of course, mortality as well. But this is the cases. So we know these vaccines are great. Some of the data coming through now suggests that higher valent vaccines will once again reduce these charts further. But it very much depends on which serotypes are in circulation in the countries that introduce those higher valent vaccines. So it's not necessarily a simple case of higher valent vaccines are better. It really depends on what's happening in your country. And there's also data coming online that suggests at the moment we have age-based strategies for pneumococcal and vaccines. So if you're over a certain age or under a certain age, you'll be entitled to those vaccines. And a lot of the data coming through is suggesting we may want to complement age-based strategies by targeting particularly immunocompromised adults with comorbidities that may be under the age limit, but they could really benefit from a pneumococcal vaccine. There's also protein-based PCVs coming, protein-based pneumococcal vaccines that should read coming, which are totally different. So we have these 3 categories now. We have the polysaccharide vaccine, we have the conjugate vaccine, which is even better, and we have protein-based vaccines coming. So once again, underscoring here, there's so much innovation in pneumonia vaccines. There's no reason to be complacent. So what does all this mean for dosing schedules? Because we've had a lot of updates and changes here. So in March last year, the SAGE group, which is the experts that advise the WHO, recommended that it would be, well, they recommended to WHO that PCV 1+1 schedules, which is a 2-dose schedule. Most PCVs are given in 3 or 4 doses, as the chart shows. But a 1+1 schedule, a primary and a booster dose, did not result in worse disease outcomes compared with higher dose schedules and was equally effective at reducing transmission. Now, this was a huge finding, and WHO moved very quickly to produce a position paper in September endorsing 1+1 schedules under very specific situations for countries with strong PCV coverage and surveillance systems. So strong results here will very much depend on having both. Now, so far, the UK is the only country to introduce a 1+1, but it's done so with extremely strong results, which you can view in the peer-reviewed literature. But now the question becomes, who else will be able to move to a 1+1, because you save an enormous amount of money as well as it simplifies the delivery. So here's the WHO guide rails for countries that would be eligible. They're suggesting PCV coverage averaging 80% or above for the 5 preceding years, or you have recent multi-age PCV campaigns where you've achieved the same level, or you've got very low levels of vaccine type carriage or disease, and you can prove that with recent quality surveillance surveys. So any one of those 3 things is fine. Plus, that's the and, you need to demonstrate that your system can reach children between 9 and 18 months. So you can use the measles dose for that, or other vaccines that are delivered in that time period. So when you look at all of that and say, okay, who would be eligible under that criteria? There are 47 low and middle income countries that meet that criteria. 25 of them, that's a lot, are Gavi eligible, and 19 are in Africa. So these are the countries that might want to consider moving to a 1+1. At the same time, WHO approved what's called fractional doses, where each child receives 40% of a PCV 13 for each of the 3 doses. Now, you can see in the picture why this might be attractive, particularly in emergency settings or in cost-constrained settings. That little vial there is a 4-dose vial, which in the current arrangements would vaccinate 4 children. But if the fractional dose was put into effect, you would be able to vaccinate 10 children with that one vial. So you can see the attraction here if you need to really reach a lot of children very, very quickly, maybe a campaign type setting or even routine. So all of this information is now available for countries and partners on the NITAG Resource Centre website. WHO, UNICEF and partners have prepared a beautiful vaccine prioritization and portfolio optimization toolkit they call VPOP, and we'll be sharing the link with that in the chat later. And countries should look at this because it gives them step-by-step guidance for how to think about moving to a 1+1. Here are all the Gavi countries who are eligible. It's a very important chart. It's in the report, which is all publicly available now. I'll be telling you where you can find it shortly. And here you have all the Gavi eligible countries with their current PCV. Most of them are using the Pfizer Prevnar. And the far column gives their PCV average coverage and also their measles, first dose measles. So they're all eligible to be thinking about a 1+1. There are also non-Gavi eligible countries that fit the criteria. In the bottom left, you'll see who they are. Many, many countries that could be thinking about this. Gavi eligible countries now have an incentive to take this very seriously. And we'll be talking more with our panelists about this shortly. Gavi is now providing countries with a new way of financing. They get one budget, one grant, one application, dramatically simplified, but it means the country has to make decisions within a given financing envelope for what vaccines they will prioritize and introduce. So there's incentives now, given that PCV is an extremely expensive vaccine, and I think it's Gavi's most expensive vaccine, and with co-financing at the country level, very expensive, with countries transitioning out of Gavi support, continuing to pay for their PCVs is a huge challenge. So 1+1 has now become an incredibly important consideration for countries. There's the Gavi vaccine budget, and you can see the orange, the huge amount that PCV has been taking up in the Gavi budget. Once again, the more countries move to 1+1, that number will drop. And also countries that have to pay for it themselves, of course, they would free up a lot of resources. Those countries that are non-Gavi eligible paying very high prices for PCV, even if they're using, they can use regional procurement platforms. UNICEF and PAHO both offer that, but not many of them are actually using those platforms to procure affordable PCVs. So many of them are paying much more than they should be. There's another way that countries are trying to reduce the cost of PCVs, and that's regional manufacturing. We have to keep our eye on this. So there's efforts in Africa, also in South America, to regionally manufacture PCV to try and reduce the price, but they're very, very early stage. We don't have anything yet. I want to plant a little seed in people's minds for how countries might be able to take advantage of 1+1 if they're eligible, to introduce another vaccine, the RSV maternal vaccine. We know this vaccine reduces pneumonia deaths, particularly among children under 6 months, where a lot of pneumonia mortality concentrates. So increasingly, countries that are eligible need to be looking at reducing to the 1+1 for PCV, potentially using the savings to introduce the RSV maternal vaccine, and then estimating what the impact on child mortality would be, pneumonia and all cause, of such a switch. And I think if they did that work, they would find that there's an enormous impact on not only child survival, but hospitalization and the costs of hospitalization if they look at a PCV 1+1 plus an RSV maternal. It's exciting stuff. PCVs also generate secondary benefits that we can't forget. They're not only a mortality reduction, but they also reduce disabilities because they reduce meningitis, and meningitis can leave children with horrific disabilities. They're also helpful for outpatient and inpatient visits, reducing them, for adults with infectious and chronic lung conditions, and they mean fewer antibiotic prescriptions. And there's a lot of new articles coming out in recent years documenting all of these secondary benefits, and the report contains links to those. There's some more detail on some of those benefits. They're really quite extraordinary. A lot of sometimes we don't consider the secondary benefits that go beyond infectious diseases, but for PCV, they're considerable with chronic lung disease. Okay, so let's continue. We're nearly to the end of the presentation. So countries now have a big opportunity to strengthen their pneumonia vaccine programs by switching to more affordable PCV products. There are great products out there. By reducing dosing to 1+1 if they're eligible, by using those savings to introduce new pneumonia vaccines like RSV, and optimizing their vaccination programs to really go after pneumonia, which is the leading infectious killer of children under 5. The report makes the case and reaches the conclusion that this is one of the most promising child survival strategies in the years remaining to 2030, which is the SDG deadline. So we encourage you all to read the report, to share it with particularly ministries of health and vaccine decision makers, so they can start to really dig deep and think about the opportunities that they now have to strengthen their PCV programs. The report as well contains a link to all of the great new resources that are available and that are highlighted in the report.